Classical chest imaging of post-primary tuberculosis. Presented by Dr. Jalil Mohsin Uddin, Associate Professor, National Institute of Diseases of Chest and Hospital, Dhaka. Common sites of post-primary pulmonary tuberculosis. Post-primary tuberculosis on radiographs typically shows parenchymal opacities, often in the apical and posterior segments of the upper lobes and superior segments of the lower lobes. Figure 1. Parenchymal involvement occurs in more than one segment in most cases. Commonly, in addition to the aforementioned typical locations, consolidation and fibronodular opacities may occur in other lobes and segments of the lungs. 20% to 45% of patients demonstrate cavitation, which is the hallmark of post-primary TB. Figure 1. Postero-anterior PA and lateral chest films show a heterogeneous opacity with bronchiectasis and cavity cysts in the right upper lobe, yellow arrows, as well as elevation of minor fissure and superior retraction of right hilum. Common radiological features of post-primary tuberculosis. Figure 2. 1. Cavitation, seen in up to 45% of cases, is a hallmark of this form. 2. Consolidation and or fibronodular infiltrates, patchy or confluent opacities with associated nodules are common. Over time, these can lead to significant fibrosis, causing volume loss and distortion of the lung architecture. Focal, patchy, or poorly defined, is also common. Both bilateral and unilateral involvement of lung fields are common. 3. Enlarged lymph nodes, especially in the hilar and paratracheal areas, may accompany consolidation. 4. Endobronchial spread can also manifest as centrilobular nodules or a tree in bud pattern on CT scans. 5. Miliary tuberculosis. 6. Tubercular pleural effusion. Figure 2. Schematic view of post-primary active tuberculosis. 1. Cavitary lesion in PTB. Cavitary lesions on chest X-rays are a common finding in post-primary pulmonary tuberculosis TB and indicate areas of lung tissue destruction. They appear as round, hollow spaces within infiltrates, often in the upper lobes and associated with areas of consolidation. Figure 3. The presence of cavities is associated with a higher bacillary load and increased infectiousness. Figure 3. Chest X-ray showing cavitary lesion on the upper left lung post-primary pulmonary TB. Active tubercular cavity with consolidation. Healed tubercular cavity, thin wall. Characteristics of tubercular cavity. Appearance. Cavities appear as round, lucent darker areas within the lung tissue, surrounded by denser, inflamed areas. Location. They are frequently found in the upper lobes, specifically in the apices due to the higher oxygen concentration in these areas, which favors TB growth. Association with reactivation TB. Cavitary lesions are particularly common in reactivation TB, where the disease has re-emerged after a period of latency. The cavities, which represent areas of caseous necrosis that have liquefied and drained into the airways, have thick, irregular walls. The presence of cavitation is a sign of active and contagious disease. The cavitary margin can be described as either smooth and regular or irregular. Thick walls over 4 mm are more suggestive of malignancy, while thin walls below 4 mm are more likely to be benign. Clinical significance. The presence of cavities is often associated with active and infectious TB, indicating a high bacillary load. Treatment. Cavitary lesions can be challenging to treat as the anti-tuberculosis medications may have difficulty penetrating into the cavity, potentially leading to treatment failure or relapse. In active post-primary pulmonary tuberculosis, cavity present usually within patchy infiltrate and consolidation. Old cavity may persist in healed tuberculosis with fibrotic scar, calcification, nodule. Fig. 4 Old cavity in healed tuberculosis with aspergilloma. 2 Consolidation and or fibronodular infiltrates. Consolidation caused by TB is indistinguishable from bacterial pneumonia. Chronic consolidation, lymphadenopathy, and the lack of response to conventional antibiotics are in favor of the diagnosis of TB. Consolidation in TB typically most commonly occurs in the apical and posterior segments of the upper lobes, as well as the superior segments of the lower lobes. Fig. 5. Fig. 5 Consolidation in pulmonary tuberculosis. Consolidation with centrolobular nodular opacities leading to tree in bud appearance. Chronic consolidation with air bronchogram due to TB in right upper lobe. Chronic consolidation may also be characterized by decreased lung lobe volume. Patchy consolidation, also known as ill-defined patchy areas of heterogeneous consolidation, is a common radiographic finding in pulmonary tuberculosis TB, particularly in post-primary TB. Fig. 6 Bilateral patchy opacity in PTB. This pattern occurs because TB infection often leads to areas of inflammation and tissue damage, resulting in the consolidation of lung tissue where air-filled spaces are replaced with fluid, exudate, and cellular debris. 4 Tree in bud pattern in PTB. The tree in bud pattern on a CT scan of the lungs, characterized by centrolobular nodules and branching, linear structures, is a common finding in pulmonary tuberculosis, particularly when the disease is actively spreading within the airways. It's also seen in other conditions like pulmonary vasculitis and interstitial lung disease. Fig. 8. Tree in bud sign marking advancing cavitary TB. The nodules are present in the right upper and left lower lobes of the lungs, with the tree in bud appearance due to small airway spread of tuberculous infection. The large left upper lobe cavity red arrow is a hallmark of post-primary TB. Fig. 9 This pattern suggests active and potentially contagious tuberculosis, especially when combined with cavitary lesions. Fig. 10 The buds represent inflammation and caseous material within the respiratory bronchioles and alveolar ducts, while the tree or stalk represents caseous material in the terminal bronchioles. Thank you all. Imaging. Classical chest imaging of post-primary tuberculosis.